That should be pretty good. Okay, let's go over each of these pathways, these 3 pathways. We'll talk about them at least at this first step, but then we'll have to look at it separately to look at all the steps. But we'll start just in the area of the spinal cord. Okay, let's say inside of the big toe, sensory, where is that information going to enter this system? Let's start with the rami. Is it going to enter posterior rami or ventral rami? Big toe?
Ventral.
Ventral. Okay, now the roots, where is it going to go?
Dorsal.
Dorsal. Bonus extra credit, what nerve level was I at?
Big toe, C5.
Big
Or,
toe,
sorry,
S1.
S1.
C5.
L5. It's either L4 or S1.
L4 is pretty good.
I thought it was.
It depends on what side. S1 is going to be lateral side. S2 can be maybe underneath.
L5 lifts the toe?
L5 is top of the toe. Yeah, that's myotone. Yeah, big toe motor is L5. Good. That's motor. It's not touching it. It's sensory.
L5 is sensory. Is that what you're saying?
The dermatome for L5 is, the dermatome for L5 is the top of the foot. The myotome for L5 is big toe dorsiflexion.
That's where the trouble is.
Yep. Dermatome versus myotome. You're like 3 years ahead of me. Took me to my senior year to figure that out. Okay. So yeah, L4 dermatome. Okay, so now we're gonna do touch. Okay, so touch, sorry, not touch. Well, let's do pressure. Crude touch or pressure. Which pathway is that?
Anterior spinal
Spinothalamic.
Spinothalamic, aka anterolateral.
Anterolateral.
So yeah, spinothalamic. So what do we do for spinothalamic? Well, we actually have our first synapse here. Right. Synapse. Here. Laminate 3/4. Again, go based on what Dr. E teaches you. This is maybe 3, 4, 5, or something else. Is he saying 3 and 4? He hasn't gotten to it yet? Okay, so from here, so say lamina 3 and 4. I'll tell you then. The lamina 3 and 4 until you hear otherwise. So it's going to synapse here. That's the first synapse. Just to give you a step back for a second, all of these, this is a somatosensory pathway. We talked about somatosensory. This is a somatosensory pathway from the body. There are 3 neurons in this chain. All the somatosensory, there are 3 neurons. We know the first one is in the dorsal root ganglion. The second one is in laminas 3 and 4, so there's only one more to know.
The thalamus one.
That's the one in the thalamus. Yeah, the third one's always in the thalamus. Well, I can draw you a little chart to keep it simple. Okay, so now this, now what happens from here? Now this actually, what I'm about to tell you is the essence or secret behind the Brown-Séquard lesion. If you can feel one side, but it can't move, the other side can move, but you can't feel it. What happens here is it crosses over, and then it goes up in the opposite anterolateral tract. It does this kind of immediately within 2 to 3 levels, but for all intents and purposes, just assume more or less immediately at that level. But it's really like maybe 2 levels, 3 levels above. Okay, now it's going to go up, and then we'll draw these pathways for the full body. But from here, we'll kind of let this go for now. But this is good catch. This is going to go up to the thalamus and then to Brodmann area 312, which is the sensory Brodmann area. We'll cover all of that together in a bit. Okay, let's say you move, now you're testing the big toes, or the toes, and you have the big toe, and you move it up, and you move it down, and you ask them if they could tell whether you moved it up or down. That's for proprioception. So what pathway are we talking about?
Wait, what's the last one? DCML?
Dorsal column medium meniscus is DCML. That's the answer.
Oh.
The one you don't know. So yeah, this does proprioception, fine touch, vibration. Fine touch, they'll also call sometimes pinprick test or 2-point discrimination.
Vibration.
Is that something like
What's that?
because when you have diabetic, like you do the test on the skin, right?
Yep.
It's the same thing.
We're testing.
Exactly.
That, but with
Oh, peripheral neuropathy?
Now, sometimes with that test, sometimes they'll just kind of do you feel it, or sometimes they'll have a sharp side and a blunt side. So you ask them to differentiate, it's sharp or dull, sharp or dull. And so you're kind of testing both because it's what it is for diabetic peripheral neuropathy. It's a peripheral neuropathy. So it's not involving these central tracts directly. It's involving the peripheral nerves, which are carrying information for all of these tracts, for the sensory nerves, particularly these two. And so you won't be able to, in the peripheral nerves, differentiate. There's not going to be damage just to this and not to that. And so you're trying to at least know, is there any innervation here? Fine touch is also a 2-point discrimination. Do you know, is it here or there? And so with the 2-point discrimination, if they don't have this, they may feel it as one crude touch because the information be traveling in there now. And then spinal landing. Just so that we remember these: crude touch, temperature.
So this one goes contralateral from the first synapse?
This one will go to the contralateral side very quickly. Very important. The other two pathways we talk about here will stay ipsilateral until the medulla. So this is the exception. One thing I like to do is I like to learn general rules and patterns and themes, and only then learn exceptions. It's much lower, you need less brain power to do that, which is why I do it. You learn a big theme for a bunch of things, and then you just pick out a couple of exceptions. Okay, so now let's do big toe. You're moving the toe up, you're moving the toe down. Proprioception, what pathway is that? Pathway proprioception, DCML. It's going to be the same area. It's L4 or L5. I'm not going to be too picky about that. And so, but what happens when it enters the spinal cord for DCML? What's the DC stand for?
Posterior. Dorsal.
Dorsal column. So it's going to go ipsilateral dorsal column and go up into the medulla.
At a specific level?
It depends on, so big toe would be L4, L5.
Oh, okay.
If it was a finger, it would be in the lower cervicals or T1.
Oh, I was talking about the laminae.
Laminae, for this, it actually will not synapse on the laminae. So the laminae are cell bodies, and you would only go there if you want to synapse. But this is not synapsing
It's
until
just
the medulla.
crossing over it or whatever.
Exactly.
Okay.
It's just crossing over. And it won't necessarily cross through them like this. I think it goes through a white matter section.
So the first one it was crude touch, and the second one now we're doing.
DCML.
Yeah, fine touch or proprioception. Yeah, we're doing the other pathway. Yeah,
Okay.
we're doing this one.
Yep.
what's the difference between crude touch and fine touch?
Crude touch is if you just kind of lay the back of your hand against someone. Fine touch if you use a toothpick to stab them. Touch them. Okay. All right, any other questions before we get to corticospinal? Okay, this one is coming down. When it's ready to leave, if we're going to the muscle of the arm, this is going to be mid-cervicals. This to the leg, this is gonna be lumbar or sacral. Once it's ready, it goes over here, synapses on the alpha motor neurons in lamina 9, and then leaves out. If it's going to, let's say, the latissimus dorsi, where would it go? Which rami?
Oh, the ventral.
Rami. What if it's going to rotatores?
Dorsal.
It would go this way.
Do those have 3 motor neurons also? For the corticospinal?
I'm pretty sure. Yeah, well, that's a good question. Because I know we have postural muscles that are innervated by tectospinal and also, that's a good question, vestibulospinal. It may be vestibulospinal, but I'm not sure. That's a really good question, if it's conscious or not. I'm not so sure.
Okay, I'm just trying to figure out what exactly we need to recognize from this. So do we need to recognize, what are those called, those little patches?
The tracks?
Okay, yeah, we need to like realize that it's going through 2 of them.
Yeah, so
That one and the blue one.
So what these are showing, when it enters here, then it's gonna be going straight up or straight down.
Okay.
Everything else is
Like
kind
a
of
pit stop.
entering or leaving. And so, yeah, you need to know the rami it's gonna travel through, the root it's gonna travel through, and at what level, if it's a specific level. Then you need to know if it's gonna synapse where, and then after that, which tract is it gonna travel in. Because this white matter, this is the only way to go up and down. And so it's like a road or a highway. Are you gonna be on the 101 or the 10 or the 143, right? So we need to know where it's gonna be.
And this last one was the corticospinal, you said?
Yes, this last one was the corticospinal. I'm trying to put motor in red and sensory in blue.
So in other words, it's coming from the
Yep.
Yep.
It's coming down this way.
motor, okay.
Coming down within that bundle.
So it's gonna synapse in the ventral horn.
Yep, it's gonna synapse in the ventral horn, specifically lamina 9, on the alpha motor neurons. If you can put all those together, you're gonna really sound like you know what you're talking about.
That's the goal.
And you might actually know what you're talking about. But sometimes it's better to sound like you are. Or you do. Okay, any more questions?
For just to confirm the DCML synapsing in the dorsal horn.
No synapse. There's no subbodies here.
synapse.
Or dorsal horn for DCML will not synapse here.
So it's just gonna continue.
Yeah, this is a really long axon from here. It's gonna
Okay, so no synapsing.
No synapsing yet.
Okay.
We have not had a synapse in the DCML. That axon, this, if you imagine this neuron, it's reaching out, if this is at the level of, lower lumbars or S, it could reach all the way from there down to the big toe, and then all the way up to the medulla. It's very tiny, but it's a very long neuron.
So the first 2 we did was ascending, and we just now did a descending.
Yeah, there you go. There you go. These terms, when you can use them, they're not so difficult, but when you're, 10 of them are thrown at once and you're not practicing using them, it gets really tough. Okay. Maybe I should erase this. Okay, any other questions before we get to the whole body look at these 3 neurons, or these 3 pathways? Okay. We're going to go step by step, but we're going to go into pretty immense detail. Now, if you don't follow all of it, that's okay. But this is, I'm going to model for you what you want to be able to do. hopefully, and you can pull this off in just a few days, really. If you just kind of get this stuff down, rehearse it a couple times, I'll have it down. All right, so we're gonna end up going to left foot. Everything's gonna be left foot, okay? Let's start with motor. We're gonna do motor to the left foot. What part of the brain are we gonna start in?
Right.
Right brain. So we have a neuron here. Let's describe this neuron. What do you know about this neuron? Its name, its location. Tell me everything you know.
Do I want to move my foot, or I'm gonna
Sensory
feel
motor.
something? What did you just say?
Yeah, this is for motor to the foot. So you're gonna move
Oh.
your foot.
So primary motor cortex.
Primary motor cortex, good. Tell me more about the primary motor cortex. What lobe? Frontal.
And in front of the name.
Postcentral gyrus. Problem area? 4. What's the zip code in the brain? It's 4.
What's a Brodmann area?
Zip code. And it's the pyramidal, they're called pyramidal cells, because they look like little pyramids. Okay, a lot of information to know about that one neuron, but you want to kind of start grouping all those together. If you're studying with your friend, don't let them just say primary motor cortex. Keep asking them the questions that I asked you until you get to all this stuff. That's how you can help your friend study better. Okay, from here, there's quite a few details that I'm not sure if you got to, but it's going to travel through the internal capsule, crus cerebri, it's going to pontocerebellar tracts, and then we're going to end up in the medulla. So in the medulla, what happens? Crossing over, also called decussation. So it's in the pyramids of medulla. Most, 90% of the fibers will decussate, but 10% will keep going down this way.
He's got us 80 and 20, but
80 and 20? Okay. So 20% will go down on the opposite side and anterior corticospinal tract, and we'll cross over later. The rest, most of them, are in this lateral corticospinal tract. Now it's on the contralateral side of the brain that it started at, but it's ipsilateral to where it's going. All right, it's already on the left, it's going to the left side. And so it's going to go all the way down, and then only at the level where it needs to go, then it's going to synapse, and then it's going to take whatever nerve, femoral nerve, tibial nerve, whatever it is, it's going to take its nerve down and innervate at the neuromuscular junction. And then you have to go to a Schmidt lecture to understand that part.
Yep.
Which you should be doing. You should be combining all this stuff together at this point. One of the assignments I would give is you want to move your big toe. Start in the brain, go all the way down. Tell me nerve root levels, all that stuff. Tell me every place that you're going from the brain to the big toe. And if you can do that, you understand stuff. It takes a lot of knowledge to get there. Okay, now let's do sensory. And so we have some sort of receptor, sensory receptor. We have Meissner's corpuscles, maybe free nerve endings, Pacinian, yeah, all these things, whatever it is. Let's start with DCML, and so actually now I'll start with spinal thalamic since we're talking about those cells. Spinal thalamic, so it's going to go up, it's going to enter the spinal cord at that level. Will it synapse around there? Spinal thalamic?
No.
Spinal thalamic, well. So spinal thalamic will synapse at that level. I'll tell you how you can remember that in a bit. We know it's going to synapse there because it decussates there. So it's gonna synapse here, and then it's gonna cross over. And then go all the way up. And then where does it synapse next?
Thalamus.
Thalamus,
Internal capsule.
internal capsule, and then it's going to end up,
Somatosensory.
Cortex.
yeah, primary somatosensory cortex. Tell me more about it. Lobe, parietal, gyrus. This is wrong. Yeah.
Okay.
Sorry, I told you, you gotta keep me honest. I make
I was like,
mistakes.
man, I had to.
Post central gyrus. Ramen. 3, 1, 2. Yes, that's exactly how it said. 3, 1, 2. Don't know why. This right here is going to be thalamus, VPL. That's the nucleus of the thalamus. I will explain the VPL, VPM, the different nuclei and stuff, and just right after this.
Yeah, give us a table of those. Are those clinically important? All of the nuclei of thalamus?
No, if you have a thalamic stroke, it's not necessarily going to pick just one. There may be parts of the thalamus that are more affected, but when we get differentiation of symptoms where only the DCML is affected, not the spinal thalamic, let's say, you have to look at where they're separate. And if they're all converging to the thalamus, if you're going to get a thalamic injury, we just assume everything in the thalamus is affected. And so when you're looking at neuro injuries, you're looking at, okay, everything that's affected should be together, but things that are not affected should be somewhere else.
Okay.
And if they're all together, the things that are affected and not affected, that's probably not what it is.
Makes sense.
Okay. That's why internal capsule is like only the answer if you have all motor and sensory from like one side. Then the internal capsule is the right answer because everything's going there. Okay, and then the last one, now we have proprioception receptors. That's gonna go up, and then it's gonna enter the spinal cord. Is it gonna synapse? Not yet, it's gonna keep going up. It's gonna synapse here in the medulla, and then it's going to decussate, and then it's gonna do the same stuff. It's gonna synapse on VPL and Brahman area 312, same end of the story.
It switches over at the medulla.
Yes, only at the medulla. Okay. Okay, so now we have to test this out. Let's say we have an injury, a spinal cord injury, let's say at the level of T4 on the left side. So we have a lateral hemisection, a left lateral hemisection at T4. If you can describe the symptoms, you understand the wiring, and you understand Brown-Séquard syndrome. Okay, left lateral hemisection. Let's go through, here's how, so this is how I draw it on the test. I draw this body template, and I would draw the pathways in to figure out what side they were, where they were going, when they were together, when they were separate. And then you go track by track. So let's start with corticospinal. Okay, we have a left lateral hemisection. What side will the symptoms present?
Right.
We're on the
Left,
left, aren't we?
because it's
And it
ipsilateral.
goes to the left leg.
Left.
Going down.
Left. What type of paralysis?
Flaccid.
Are we in the peripheral nervous system?
Flaccid.
Spastic.
Oh, spastic because we're not in the CNS.
Yeah, no, this is CNS. CNS is spastic. So because we damaged the spinal cord, it damaged the tract. The tract, well, I erased it. The tract is central nervous system. Central nervous system is spastic paralysis, hyperreflexia, hypertonia. I had one patient who had to get Botox shots in his forearm every 6 months or more because to deal with the spastic paralysis. Okay, left spastic paralysis and all the other symptoms that go with it. You should be able to list at least 5 or 6 symptoms that go along with upper motor neuron lesion. That's what this is. Upper motor neuron lesion. You talked about upper motor neurons, right? Okay, they're simpler than sometimes I see. This is an upper motor neuron, including its entire axon, and this is the lower one. Why is this called upper and why is this called lower?
It's upper and lower.
One's up above the other one. So this is the low one. It's a descending pathway, it has to be that way. Okay, we ready to move on to the next pathway? Let's look at DCML. DCML, the DCML pathway on the left side of the spinal cord, where does it end up? Left or right foot?
Left.
Yeah, this DCML, this is spinal thalamic on the other side. So the left DCML, since it hasn't decussated yet, is coming from the left foot. So we will have left loss of what? Be more specific.
Fine touch.
Fine touch. What else?
Vibration.
Vibration and proprioception. Good. On the left side, which happens to be the ipsilateral side of the injury. So these are both ipsilateral. And notice how, because the injury is here, we don't care about where it comes from in the brain necessarily. That's out of the picture. It's here now, and so if it's injured here, where was it coming from or going to? What part of the body will you see the symptoms? Because this is what we're seeing. When you're at the doctor, this is what you're seeing. You're seeing the symptoms in the leg, and they move their leg and they feel their leg. That's what you're testing. You're testing this. So we're looking about those two. That's what we care about. Okay, last one, spinothalamic. Okay, I have to kind of phrase the question differently, but if we cut the left side of the spinal cord, are we affecting the spinothalamic tract that came from the left side?
No,
Why not?
because it's contralateral.
It's on the right side. And so which spinothalamic tract is here?
The right one.
Yeah, it's one that's going to the right side. So the spinothalamic tract that's coming from here will go down, and then it will, actually I should draw them up. It will synapse here, and then cross over and go up. And synapse there. And so if we cut this, we're going to get a loss of right pain, temperature, crude touch. So if you cut off, we're doing a left lateral hemisection, so we're just cutting it. This half is being severed, and so everything below, since it's spinal cord, everything below this level will lose ipsilateral motor, ipsilateral vibration proprioception, contralateral pain, temperature, crude touch. I don't expect that you know it now just from me telling you. I expect that you would have to draw it several times to get it in, and you should. You can pick a different color for each pathway, draw on left and right, or if you have 6 colors, different color for left and different color for right, and then just put lesions. What will be affected? Everything you cross out is affected. Everything you haven't crossed out is not affected. And then you just look at what part of the foot, or which leg they went to, or came from. if you understand this enough, when you start to get the lesions, I mean, it almost feels like cheating. You just draw it out, you draw the pathways, and then it's like you don't even have to memorize it.
It confused me, we had two blues, so
I
that's
know,
okay.
I know, that's why I
I'm gonna
label
go
it
home
afterwards.
and.
Yeah, I label it afterwards when I realized I made that mistake.
That's right.
Usually when I do that part, I do flip, I do each pathway in a different color. There we go. Okay. Any questions? That's Brown-Séquard syndrome. That's what that is.
What?
Brown-Séquard syndrome.
T4.
It's one of the more important lesions, particularly of the spinal cord, because if you understand these are the symptoms of it. Instead of left or right, you can say ipsilateral and contralateral. If you understand these symptoms based on that type of injury, which is for a Brown-Séquard lesion, you have to understand the wiring of the spinal cord, unless you just rote memorize, which means you have to know the wiring of these three pathways, which I think are the most important in the spinal cord. Low on time, but all right, so I want to show you the simple trick. Let me erase that since I don't want to erase everything over here. Okay, how many neurons are in the somatosensory pathway? Well, let me ask a different question. What's the three-letter designation of somatosensory? How would you categorize it?
312 or the 4? Oh.
SSE?
Is it general or specific?
General.
Yeah, it's just touch. General. Is it somatic or visceral?
Somatic.
Is it afferent or efferent?
Afferent.
GSA. That's another thing where if your classmate or your study buddy is asking questions, pepper them with those questions. If you notice, a lot of my questions are just asking you to get more specific. Tell me more about it.